It's a pleasure to be speaking to you today. It'll be even more of a pleasure to meet some of you, perhaps tomorrow. I'm going to talk about the role of social prescribing in relation to inequalities in health. Let's look first at what's been happening to life expectancy in Asia, in the Asia-Pacific high-income countries. Really quite remarkable. Look at Singapore, how much life expectancy improved from 2000 to 2018. That's blue line is the improvement. Dramatic. Hong Kong now has the longest life expectancy in the world, longer than Japan by half a year. And similarly for women. And Singapore is right up there. Even in the poorer countries of the region, or maybe especially in the poorer countries of the region, massive improvement in life expectancy. So the inequalities between countries have, to some extent, got less. They've diminished. A great achievement. I want to talk about England as an example, because we have such good data and because I've been very much involved in what's been happening. After I chaired the World Health Organization Commission on Social Determinants of Health, we reported in 2008, and after the WHO Commission, I was invited by Gordon Brown, then UK Prime Minister, to answer the question, how could we apply the findings and recommendations of the Global Commission to one country, England? And I conducted a strategic review of health inequalities. We reported in 2010. In 2020, just before the pandemic crashed upon us, we published Health Equity in England, the Marmot Review, 10 years on, looking back at what had happened in the previous 10 years. Life expectancy, going back to 1980, I could go back to 1900. Life expectancy had been improving for women and men by about 1 year every 4 years. In 2010-11, there was a break in the curve and a slowdown. What happened in 2010? We had a change of government, conservative-led coalition government. A bit sensitive about this. They said, surely you can't be suggesting it's anything we did that led to this slowdown. That's assuming they cared at all. Maybe we've just reached peak life expectancy. It's got to slow sometime. So we looked at other countries. Life expectancy improvement, Estonia, Norway, Slovakia, Hungary, Denmark. There's the UK. We had the slowest improvement of any rich country except Iceland and the United States. No, we had not reached peak life expectancy. And even further, inequalities in health had got bigger, and life expectancy for the poorest people outside London had gone down, actually got worse. In dealing with the question of what should we be doing about health inequalities, I want to put up some apparent opposites. Is this a social problem or a medical problem? Now, in fact, for all my apparent oppositions, social or medical, the answer is yes, it's both. It's a social and it's a medical problem. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. Yes, of course, the healthcare system is vital, but we need to address the conditions that make people sick. But there's a halfway house. health care professionals can do a great deal to address the social determinants of health. I stimulated the nurses to produce Nurses for Health Equity, guidelines for tackling the social determinants of health. I spent a year as president of the World Medical Association, and we produced a report, Doctors for Health Equity, on what can doctors do to address the social determinants of health. And social prescribing is part of that. It means addressing people's needs in a holistic way. There are primary care centers in Britain now that say the majority of what they do is social prescribing rather than writing prescriptions, whether it's recreation, cooking, nutrition, occupational training, and the like. A great deal can be done. So not social or medical, but both. Disease control or social determinants. Let's look at COVID. A great deal of emphasis has been placed on controlling the virus for COVID, vaccination, social distancing. Here, we've classified people by where they live and classify where they live by level of deprivation. In England, the dark green is all-cause mortality, a remarkable social gradient. The greater the deprivation, the higher the mortality from all causes. Remarkable, not just poor people with worse health, but the less the deprivation, the lower the mortality. And there's COVID-19, more or less identical gradient to that from all causes. So yes, we need disease control. We need to control the virus, but we also need to address the underlying inequalities. Look at this. Deprivation, disease outcome, gradient in caries in 5-year-old children. Looks identical to the COVID-19 gradient. I was talking to people involved in primary prevention of cardiovascular disease in primary care. And I showed this gradient, obesity prevalence in year 6 children. What's going on here? COVID's caused by a virus. Dental caries is caused by diet and low fluoride, whatever. Obesity is diet, exercise, stress, but not a virus. So yes, we need disease control, but we need to address the... So if we're going to address the social determinants, these were the 6 domains of recommendations that came from my English review in 2010. Give every child the best start in life, education and lifelong learning, fair employment and good work for all. Number 4, everyone should have at least the minimum income necessary for a healthy life. Healthy and sustainable places and communities in which to live and work, and taking a social determinants approach to prevention. Give every child the best start in life. What would that look like? Under 5 mortality rates per 1,000 live births by wealth quintile. So if we look here, India, for example, this remarkable social gradient in under 5 mortality. Nepal, similarly. Thailand has more or less abolished the inequalities apart from a higher rate in the poorest 20%. So it's possible to make a huge difference to these inequalities. And you can see in general, the between country differences are bigger for the poorest 20% than they are for the richest 20%. Wasting and overweight prevalence among children under 5. Africa, wasting and overweight. Eastern Mediterranean, wasting and overweight. We've got this dual burden going on at the same time. And giving every child the best start in life. Actually, the global inequalities have got less in infant mortality. 1990, this was the African region, just about 105 per 1,000 live births, whereas in Europe, it was less than 30. Europe improved, but Africa caught up, now 50 compared with 8. So the absolute gap has got much less. There's Southeast Asia. And even in the rich countries, we see these issues of social gradients and between country differences. We compared 7 major diseases in middle-aged Americans and English. There's the social gradient in heart disease by income in the US and England. And for each of these diseases, the Americans were sicker than the English. It's consistent with what I showed before of the improvement in health from 2010 was slower in the US than it was in the UK. Let me come back to that slow improvement pre-pandemic and to what happened during the pandemic. This from American colleagues. Life expectancy in the US dropped between 2019 and 2020, dropped further in 2021. And these were the countries that did similarly poorly, not as bad as the US, Scotland, Northern Ireland, Germany, and England and Wales. Really interesting. The countries that had poor health in the decade pre-pandemic had big falls in life expectancy during the pandemic. What's the link? So in the UK, for example, pre-pandemic, life expectancy was stalling, inequalities were increasing, and life expectancy for the poorest people was falling. And that slowdown in life expectancy was nearly the slowest of all rich countries. And in the first wave of the pandemic, we had the highest excess mortality. When I say nearly the slowest, except the United States, and over the 2 years of the pandemic, the drop in life expectancy was biggest in the US, but then the countries of the United Kingdom. And the link between these two, I suggest poor governance and political culture, increasing social and economic inequalities, the reduction in spending on public services, and we weren't very healthy coming into the pandemic. Another apparent opposite, social determinants or individual responsibility. We have endless parades of politicians who say the problem is poor people just don't know how to eat properly. The problem is ignorance and laziness. Well, that's not what the data show. Here's the most deprived 10% of households. If they were to follow the NHS healthy eating guidance, they would need to spend 74% of household income on food. They're not lazy, they're not ignorant, they're not feckless. They're poor. Don't blame poor people, blame their poverty. So yes, individual responsibility. The people in the top 10%, if they feed their children unhealthy food, they're being irresponsible. But if people in the bottom 10% feed their children unhealthy food, they're being poor. And that relates right through the life course. Association between socioeconomic position and school readiness in children aged 5 to 6. By socioeconomic position, low, middle, and high, physical health and well-being, social competence, emotional maturity, language and cognitive development, communication skills, and general knowledge. So if you want people to be competent adults and be able to take the actions that they needed to take to have healthy lives, invest in reducing these inequalities in early child development, children aged 5 to 6. Health-related quality of life measures between households living below the poverty line compared to the general population in Hong Kong. So that's below the poverty line. General health, mental component, summary score, physical component, vitality, mental health, bodily pain, social function, role, physical, emotional, physical functioning. All much worse in people below the poverty line than in households above the poverty line. Suicide by quintile of deprivation. The greater the deprivation, the higher the suicide rate for women and for men. So it's not a matter simply of blaming individuals. We need to deal with the social conditions. Targeted or universal. The classic British approach to social policy is you target the worst off. A more Nordic, Northern European approach is universalist systems. I tried to combine them. I called it proportionate universalism. What we want is, I said, universalist systems with effort proportionate to need. To illustrate, we could call it leveling up. If this was less deprivation, higher life expectancy, if we intervene only on the poorest, we miss the health disadvantage of those further up the gradient. So, universalist systems with effort proportionate to need. What did we get in Britain post-2010 when the health picture was not looking good? This is spending by local government per person. In the least deprived 20% of areas, after 2010, the spending went down by 16%. And then the greater the deprivation, the greater the reduction in spending. In the most deprived, it went down by 32%. What we've got here is effort inversely proportionate to need. The greater the deprivation, the greater the need, the greater the need, the greater the reduction in spending. Could this have played a role in the slowdown, in improvement in health, the increase in inequalities, the decline in life expectancy in the poorest areas? Yeah, I think it could. And coming back to the work we're doing in Hong Kong, the percentage of children in poverty after a cash policy intervention, pre-intervention, post-intervention, that's not bad. Giving cash to poor people reduces the poverty level of children. Central government or local action? In Britain, coming back to Britain, child poverty defined as living in a household at less than 60% median income. Pre-housing costs, 18% of children were in poverty in 2010-11. After housing costs, that was 27%. And that went up to 30%. So we do want central government action. They set the child poverty level. But if central government is taking action that's likely to make health inequalities worse, then we do need action at local level. We did a report for Greater Manchester, Institute of Health Equity, Build Back Fairer in Greater Manchester, Health Equity and Dignified Lives. Similarly, in Cheshire and Merseyside in Britain, Altogether Fairer. And we've been working with integrated care systems. Comes back to social prescribing. What can these integrated care systems do to address the social determinants of health? And we've been working with business. Legal & General, a large insurance company, announced it had formed a long-term partnership with me and the Institute of Health Equity. And we said there are 3 things business can do. Improve conditions for employees, goods and services for clients and customers that could be good for health or bad for health, and behaving like anchor institutions, looking at the impact on the community and the environment of their activities. To conclude then, I have my 6 principles dating from 2010. Give every child the best start in life, education and lifelong learning, fair employment and good work for all, having enough money to live on, healthy and sustainable places and communities, and a social determinants approach to prevention. We need all 6 of these to address health inequalities. We've now added 2, tackle discrimination, racism and their outcomes, and pursue environmental sustainability and health equity together. But we also need to address what I said before, poor governance and political culture, the increasing social and economic inequalities, the reduction in spending on public services, and we need healthier populations. One recommendation: put a fair distribution of health and well-being at the heart of all government policy.